Which criteria do you use to diagnose the presence of congenital heart disease? You are the doctor on duty and you gave me a call. Anand sir, I think I've admitted one child and I think it's a case of some congenital heart problem. Manka, why? Why do you know it's a case of congenital heart disease? Are you able to hear some murmur? So yes, now very importantly, to diagnose a congenital heart disease, we follow a criteria known as NADAS criteria. It is known as NADAS criteria. Now, NADAS criteria, very importantly, it is divided into major and minor criteria. NADAS criteria, it is divided into major and minor criteria. What is major criteria? Now, in major criteria, if you are able to appreciate systolic murmur grade 3 or more, systolic murmur grade 3 or more. Eventually, I'll tell you what are the grades of murmur and stuff like that. You'll get a good idea. So, the very importantly, the pointers for the major criteria for NADAS criteria are systolic murmur grade 3 or more, any diastolic murmur, any diastolic murmur if you're able to appreciate, or the patient has C and C. C for the patient will have cyanosis, or C for the patient will have a congenital, very importantly cyanosis, or you can say that the features of congestive heart failure. If the patient has feature of congestive heart failure, I'll repeat again, if the patient has the feature of congestive heart failure, as in crepitations in the chest, as in raised JVP, periorbital swelling, facial puffiness, like that. So I'll repeat again, the NADAS criteria is divided into major and minor. And major criteria, we have systolic murmur grade 3 or more, any diastolic murmur, or C for cyanosis if the patient has, or C for congestive heart failure. Now, what are the minor criteria? In a case of minor criteria, so if systolic murmur grade 3 or more is major, then minor comes as, the minor is systolic murmur less than grade 3. Systolic murmur less than grade 3, and very importantly, any abnormal finding you get, abnormal second heart sound, either abnormal ECG, blood pressure, or chest x-ray. Abnormal second heart sound, ECG, blood pressure, or chest x-ray. So these are the major and minor criteria for NADAS criteria. Very, 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 very important for the exam purpose. UGPG residency program, this, that, everything, you get this question. Okay. Now, very importantly, I told you about the major, minor, everything I've told you. Only one thing, remember that one major or two minor, one major or two minor are the cutoff for the NADAS criteria. Can you name some other condition where this major minor criteria? Is there any other? So in a case of acute rheumatic fever, we have the revised Jones criteria. Have you heard this name? Yes or no? Where do you use revised Jones criteria? So revised Jones criteria you have in acute rheumatic fever. And acute rheumatic fever, remember always 1 plus 2. It is one major and two minor. To say it a positive acute rheumatic fever Jones criteria, there should be one major and two minor positive, whereas in NADAS it is one major or two minor positive. So this is one correlation which I took a lot of time to double check, and this is important, so please remember. Now, I said systolic murmur grade 3 or more. Systolic murmur grade 3 or more. Firstly, question, very basic question. Baba, tell me the grades of murmur. How many murmurs are there? How many grades are there? So please remember, question, how many grades are there? Please remember, there are 6 grades of murmur. There are actually 6 grades, total 6 grade of murmur is there. And I'll show you the grading of the murmur. So yeah, now this is a very important slide. In general basic knowledge, you should know there are 6 grades of murmur. If the murmur is very faint, maybe heard by an expert, then it is a grade 1. Very faint murmur is grade 1. If the murmur is soft, but it is heard in all positions, all the areas it is heard, but it's very soft, that is grade 2. Listen, hello, you are watching this video for the first and last time, okay? So don't watch it just like that. Tell yourself you're reading this for the first and last time, and forever next 70-80 years of your life you will remember the grades of murmur. What happened in grade 1? Who will tell me? Tell me, what is the grade 1 murmur? Grade 1, say yourself, it is very faint. What is grade 1 murmur? Very faint. Grade 2 will be soft, it will be heard in all positions. Say again, grade 2 is soft, it will be heard in all positions. Moderately loud is grade 3 and loud is grade 4. Moderately loud is grade 3, then loud is grade 4. So it is very faint, then soft, then moderately loud and loud. Now the MCQ was, which one is associated with a palpable thrill? If you put your finger like that parasternal area, which one will have a palpable thrill? So this is the MCQ. So grade for murmur is loud and it is associated with a palpable thrill. So one is loud. Can I remember loud, very loud and loudest? Yes or no? Loud, very loud and loudest. So loud, very loud and loudest. Loud with thrill is grade 4. Loud with thrill, heard with the stethoscope partially of the chest. Little bit steth also is out of the chest. I'm able to still able to appreciate it. And grade 6 murmur, oh my god, that is with thrill obviously and heard with the stethoscope entirely of the chest, just above the precordium, not touching the skin, like just without touching the steth. Also steth is all out and I'm able to appreciate it. So that is grade 6 murmur. So I'll repeat again, there are 6 grades of murmur. Grade 1 is very faint, grade 2 is soft, which is heard in all positions, grade 3 is moderately loud, grade 4 is loud with a thrill. Loud with a thrill, loud has a L and thrill has a L, loud with a thrill. Grade 4, grade 5 is very loud and steth partially of the chest, and grade 6 is loudest, whereas and steth is entirely of the chest. Now tell the syndrome and tell the congenital hearts associated, which is important for exam purpose, is Down syndrome. The most common congenital heart disease in Down syndrome is endocardial cushion defects. The most common congenital heart disease in Down syndrome is the endocardial cushion defect. They also ask a question, the most common congenital heart in Holt-Oram syndrome. The most common congenital heart in Holt-Oram syndrome is ostium secundum type of atrial septal defect. Ostium secundum type of atrial septal defect. What I'm telling you right now initially are the exam questions. The most common congenital heart in Allegili syndrome, very importantly, is pulmonary stenosis. The most common congenital heart in Allegili syndrome, it is pulmonary stenosis, number 1. Number 2, which is the most common congenital heart in Williams syndrome? In Williams syndrome is a supravalvular aortic stenosis. Supravalvular aortic stenosis. The most common congenital heart in Williams syndrome is supravalvular aortic stenosis. This is a very straightaway exam question. The most common congenital heart in Down syndrome is endocardial cushion defect. In Holt-Oram syndrome is ostium secundum ASD. In Allegili syndrome is pulmonary stenosis. And Williams syndrome is supravalvular aortic stenosis. If I get the full slide over here, this one, the other one, the most common, the congenital hearts in Apert syndrome, that is coarctation of aorta and VSD. Ellis-Van-Creveld syndrome is single atrium and ASD. TAR syndrome, thrombocytopenia absent radius syndrome, A for absent, A for atrial septal defect, and DiGeorge, it is cardiac outflow tract defects, and even tetralogy of Fallot. This was the MCQ. The congenital heart associated with DiGeorge syndrome is tetralogy of Fallot. So that's it. So this part is done. And Allegili syndrome was a NEET SS question. The most common congenital heart in Allegili syndrome is pulmonary stenosis or peripheral pulmonary stenosis. And very importantly, in Allegili syndrome, which vertebra do you see? Butterfly shaped vertebra. So we all know, where do you see butterfly shaped vertebra? The answer is Allegili syndrome. And Allegili syndrome is this paucity of the bile ducts, the biliary tract, biliary atresia, bile duct rukavat, that bile duct stoppage or obstruction is there. So that's why the patient might have jaundice plus minus. Okay, remember that's a biliary tract problem, little bit of jaundice, and butterfly shaped vertebra. That's it. Yeah, rest all we have done. The most common congenital heart in Cry-Duchard syndrome, everything in Cry-Duchard is common, ASD, VSD, PTA, so it's not important for the exam purpose. Now, next important point we have, remember, in the end, we only regret the chances we didn't take. In the end, we only regret the chances we did not take. Life is beautiful, okay? Life is amazing. I know it's tough, but I know it's difficult, but difficult does not mean impossible. Difficult doesn't mean impossible. Everything will make sense. Everything will be fine. You just have to breathe and take baby steps, one step at a time. We always say change is never painful. It is the resistance to change is painful. Change is never painful. People come and go is not a problem. Resistance to the change. I have kept myself mentally attached to someone, that is the problem. Now, very importantly, Lutembacher syndrome. Lutembacher syndrome has like a one-liner kind of a thing. In Lutembacher syndrome, the patient will be suffering from ASD with a mitral mitral stenosis. The patient will have a atrial septal defect with mitral stenosis. In your question, if the patient has an atrial septal defect with mitral stenosis, definitely you can think of Lutembacher syndrome. And remember, if I'm this is a this you know na this is a mitral valve. If this is the mitral valve and the patient has a mitral stenosis, and we all know ASD is a left to right shunt because the what you call left side of the heart has a higher pressure than the right side of the heart. So you're gonna have definitely right atrial hypertrophy. You're definitely gonna have right ventricular hypertrophy. So right atrial hypertrophy, right ventricular hypertrophy, and even pulmonary artery hypertension or pulmonary stenosis eventually the patient can have over Lutembacher syndrome. So straight away one liner, it is atrial septal defect with mitral stenosis. So it is a congenital atrial septal defect which is complicated by mitral stenosis. That is the background of the Lutembacher syndrome. And the most common congenital heart disease in Lutembacher syndrome is a ostium secundum type of atrial septal defect. Ostium secundum type of atrial septal defect. So this is straight away very nice, to the point, and that's it. Next important point, okay, this all you know only actually. Can I say because of the atrial septal defect, just now I told you the patient will have more left to right shunt, more because mitral stenosis is also there, no? So more left to right shunt means more right atrial and right ventricular hypertrophy and more pulmonary artery stenosis or pulmonary artery problem or pulmonary artery dilatation. So that's it. Very importantly, yes, that's true. And yeah, this is very nice point. And that is because of more and more left to right shunts. So more and more the patient can have the features of infective endocarditis. VSD, actually, it is the most common congenital heart which is affected by infective endocarditis. And in VSD topic, I've already explained why VSD patient can have infective endocarditis. But the patient ASD with the mitral stenosis, it will almost more and more again pressure to the pulmonary area and also to the heart, causing infective endocarditis. So two things: the most common congenital heart as affected by infective endocarditis is VSD, and ASD with MS also can have a infective endocarditis. That's it. So this part is done. Yeah, we have done that problem. Yes, this is a very nice question. What is differential and what is reverse differential cyanosis? If your lower limb are more cyanotic, then your upper limb, that is known as differential cyanosis, and opposite of that is reverse differential cyanosis. When your lower limb are more cyanotic than your upper limb, that is differential cyanosis. And when your upper limb are more blue than the lower limb, that is known as reverse differential cyanosis. Now with examples and explanations, very straightaway questions. Okay. Remember, in a case of PDA with reversal of shunt, or I can say PDA with a pulmonary artery hypertension, which is almost talking like a reversal of shunt. So let's learn about it. PDA. We all know that this is patent ductus arteriosus, which is a left to right shunt, right? We all know that because the left side of the heart has a higher pressure than the right side. So PDA is always a left to right shunt. Now I said in a case of PDA, PDA with reversal of shunt, my lower limb will be more cyanotic than my upper limb. Very simple, very easy. Understand the concept. Now, PDA with the reversal of shunt. Reversal of shunt means kind of a pulmonary artery hypertension. I can write in simple words, pulmonary stenosis. Imagine you have a PDA and imagine eventually the patient develop pulmonary stenosis. So PDA was a left to right shunt, but PDA with pulmonary stenosis, automatically this is a right to left shunt. Are you understanding? Because there is a pulmonary stenosis, no blood कैसे जाएगा? PDA से left से right में आके pulmonary artery में जाने को ready तो है, पर अब पेशेंट को डेवलप हो गया है पल्मोनरी स्टेनोसिस। तो जो ब्लड लेफ्ट से राइट आके पल्मोनरी आर्टरी जा रहा था, अब वो नहीं जाएगा। तो पेशेंट को लेफ्ट टू राइट शंट की बजाय राइट टू लेफ्ट शंट हो जाएगा। आर यू अंडरस्टैंडिंग? इन नॉर्मली इन पीडीए द ब्लड वाज गोइंग फ्रॉम लेफ्ट टू राइट, like from the left to the right to the pulmonary artery. Now we have PDA with pulmonary stenosis. Now, so it won't be a left to right shunt. Now it will be a right to left shunt. So mixing of basically the mixed blood, or I can say yeah, exactly. There's a mixing of blood, because left side is fresh blood and right side is deoxygenated blood. So mixed blood, basically, yes, it is going to the aorta. Now, very importantly, remember, guys, listen very carefully. The fresh blood, the happy blood in our body, the oxygenated blood in our body, it basically enters the left atrium with the help of pulmonary veins. Yes or no? Do we know that? Yes or no? Normally, the oxygenated blood with the help of pulmonary veins enter the left atrium. From the left atrium, it goes to the left ventricle, and from the left ventricle, obviously, the blood goes to the aorta. The happy, fresh oxygenated blood basically enters the left atrium, left ventricle, and aorta. Aorta before touching the PDA. This line is very important, okay? Aorta before touching the PDA. Aorta before touching the patent ductus arteriosus, it quietly gives a branch to the right brachiocephalic trunk. This is very interesting. Aorta before touching the PDA, quietly it gives a branch to the right brachiocephalic trunk, which basically supplies the right subclavian artery. Right brachiocephalic trunk, which supplies the right subclavian artery, and right subclavian artery supplies the right upper limb. Right subclavian artery supplies the right upper limb. So can I say the right upper limb has the most fresh and most oxygenated blood? Yes or no? Because naturally there is no PDA mixing here. There is no touching of PDA to the aorta, because aorta first from the left atrium to left ventricle to aorta. Aorta gives a branch to right brachiocephalic trunk, then right subclavian artery, and it supplies the right upper limb, and followed by the left upper limb, right upper limb, then left upper limb, and after that aorta actually meets the PDA. Imagine, after supplying everywhere, first to the right upper limb, then to the left upper limb, and then the aorta meets the PDA, and then the mixing of the blood will happen, which we know PDA with pulmonary stenosis, and then the blood goes down. So that is why, can I say now my lower limb will be more cyanotic than my upper limb? Can you say that? Yes or no? Now understood. Now did you get the concept, right? Because now the lower limb will be more blue than my upper limb, because upper limb has got the most fresh blood, and then aorta meets the PDA, and then we're gonna have a mixing state, and that's the whole story. So same, this background, this mechanism, this rational explanation is for everything. For everything, what I mean to say is this one. The examples of differential cyanosis where the lower limb is more blue than the upper limb, I told you PDA with reversal of shunt, right? So PDA with reversal of shunt, and all these also have the same explanation why the lower limb are more blue than the upper limb. Same, for example, coarctation of aorta. Same story, only coarctation. So this is basically the aorta, and this is the coarctation, kind of a aortic obstruction, aortic stenosis. Coarctation of aorta is like aortic stenosis. So again, the fresh blood goes to the left atrium and left ventricle, and then to the aorta. This fresh blood was supposed to go to the aorta and the whole body, but because the door is narrow, because the road is very closed and very narrow, can I say very less blood will go down? So less blood will go down. So again, the same answer, that my lower limb will be more cyanotic than my upper limb. So all the aortic problem, aortic stenosis, coarctation of aorta, interrupted aortic arch, pulmonary artery hypertension, pulmonary stenosis also, yes. So pulmonary stenosis also, yes, very importantly, we're gonna have all these are causes, are the examples where the lower limb will be more blue than the upper limb. That's it. Okay, that you should know. Means, what is the background? The main line is desaturated blood from the ductus enter the aorta distal to the left subclavian artery. The aorta was meeting the PDA distal to the left subclavian artery, sparing the brachiocephalic circulation. Means aorta meets the PDA. after meeting right upper limb and after meeting left upper limb. When aorta meets the PDA, then they do mixing, and then it is blue, 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 blue. So that is a very beautiful point. What is reverse differential cyanosis? Reverse differential cyanosis is when my upper limb are more blue than my lower limb. What are the examples we have when the upper limb is more blue than my lower limb? That also is very easy. Now remember TGA with reversal of shunt. TGA with pulmonary hypertension or TGA with reversal of shunt. Why in TGA with reversal of shunt or TGA with pulmonary hypertension, you will have upper limb more blue than the lower limb? See, it's very easy. Now, this is a TGA. TGA is transposition of great arteries. Normally, this side we have the pulmonary artery and this side is the aorta. But whereas in a case of TGA, this becomes the aorta and this becomes the pulmonary artery. This is a TGA. And now TGA with pulmonary hypertension, or kind of a pulmonary stenosis. In a case of TGA, if the patient has pulmonary stenosis, now in TGA, what happens? The deoxygenated blood basically enters the right side and enters the aorta. From the aorta, the deoxy blood goes to the whole body and back to the right side. Whereas in the left side, the happy oxygenated blood enters the left atrium, left ventricle. This happy oxygenated blood should have gone to the aorta and the whole body, but here it is going to the pulmonary artery, and pulmonary artery are connected to the lungs. Right? This is what the story is happening. Now we have a TGA with pulmonary stenosis. Now TGA with pulmonary stenosis. So very importantly, remember the happy oxygenated blood goes to the left atrium. Like in general, we know that the oxygenated blood from the lungs go to left atrium and left ventricle and to the pulmonary artery. But I have developed pulmonary stenosis. Now this path basically it is blocked. When this path is blocked, now through the PDA, the students will go to the right side. Through the PDA, the blood basically will go to the right side. So through the PDA, the blood will go to the right side, and that is why the blood from left atrium to left ventricle to pulmonary artery, from the ductus arteriosus to the descending aorta. Now, very importantly, in this case, very importantly, the upper limb will be more blue. Now, again, aorta, this aorta before meeting the PDA has already met right upper limb and left upper limb. Remember, aorta before meeting the PDA has already met the right upper limb and left upper limb. So, right upper limb and left upper limb, the upper limb, they are very, very, very badly blue. After that, when aorta meets the PDA, where the PDA is now helping them, which is basically bringing the fresh blood from the left to the right. So naturally now upper limb will be more blue than the lower limb, because upper limb will be more blue than the lower limb, that you should know. So these are the important pointers we have. And yeah, these all things are there. The other causes for reverse differential cyanosis is TGA with pulmonary hypertension, dextro TGA with VSD, supracardiac TAPVC, and persistent pulmonary hypertension of newborn. This is like very hi-fi question which they can ask in the exam, so that you should know. I made a chart also, duct dependent pulmonary and duct dependent systemic circulation. Okay, that you should know. Okay, once again.